Hello and welcome to the Integrated Rehab and Performance Podcast. My name is Dr. Nick Curtis and I'm running the show here at the Integrated Rehab and Performance Center. Today we are going through an example of a day one exam regarding maybe a performance client or patient who had some issues that they were looking at regarding their snatch technique, their ability to be stable and strong at the bottom of a snatch. They had some previous issues with their right knee that was giving them some residual problems and a ton of mobility issues, whether they knew it or not, that was limiting their ability to sit in the bottom of snatch comfortably, own that position, and then be able to push out of it. So again, operating on a body that was not very comfortable at the bottom of that snatch with a lot of compensations that allowed them to be still fairly successful in CrossFit and had pretty heavy snatch, but again, was still limiting their ability, and they knew it to be able to kind of thrive in that with a snatch and other squat and deep squat positions. So we're going through specifically the lower extremity part of the assessments that were done, that you'll be able to see the thoroughness and how deep we dive into the different joints and everything involved, whether it's a pain patient, right, someone who's got some discomfort, or if it's just a purely performance patients or clients that is looking to improve the way they move and prevent pain and injury in the future, which is certainly what a big goal of what we were doing here, right? Because when you're unable to be comfortable in this position and yet you are loading it very, very heavy, things are destined to come down and prove injury to come in the future. So again, these are some of our goals that we're working on, and it's going to give you we're going to walk through some of the things that we did. I'm going to describe kind of the overall methodology, and you'll see just a glimpse of some of the work that we've done in the day one exam for this patient. All right, if I were to describe the patient exam flow, whether it is a pain rehab patient or a performance patient, one thing that we do with everyone is that's what we call an SFMA top tier screen. So this helps us identify which global or broad multi-joint movement patterns are showing signs of either severe range of motion loss or motor control issues, or just asymmetry from side to side, which is really important, especially in terms of injury prevention, is when we notice one side being or just showing a major difference compared to the other side. After that, we always go into more precise but still relatively broad movement pattern testing. In this case, it might be very specific to the patient's goals, the movements that they do on a daily basis, or their activities that they enjoy. So whether it's pickleball, CrossFit, golf, or hiking, whatever it is that they enjoy, we have some tests that we can do that more mimics their activity. And we videotape everything we do, especially in this day one, to help reference in the future. Again, it helps show the patient what they're doing as opposed to what they're feeling, which is important because a lot of times what we feel is different than what's actually happening. So to make sure that they can see that as well, we can always go back and compare. After we do more precise, and will be just different from patient to patient, we'll go into precise mobility testing, which is it'll be the same mostly for everyone, but we might focus on certain joints over others. Again, this is a table test, and we get them on the table. We're going to look at the range of motion for just about every joint and make sure that everything is lining up. Usually they're not, and we will be able to kind of tell a story. You can almost consider it like a chessboard when we're doing this testing, is we go from the top tier global movement patterns, and then we whittle it down to the more specific joint by joint. What is this joint capable of doing? And we have that written down, all the important information on a board, and it starts to tell a story of where the asymmetries are, where the mobility losses are, and then we get to really hone in on which ones are really related to the major goal or task that brought the patient in the first place. After that, we do a chiropractic exam. This is more looking specifically at the spine and the joints, where we're looking at joint play mostly, which is where have we lost mobility at certain in the spine, which spots. From there, we also go on to the extremities. We can see where's the joint play loss in certain joints, which directions are they in, which movements are they in, and then which ones are related, again, to that more precise mobility testing, in which case which ones are related to more of that broad mobility testing and that top-tier global screen. So we can see which ones are, when we do a toe touch test, there's many joints involved in performing that motion. So if we see a limitation, we're like, oh, you have limitation in the toe touch test, The more precise mobility testing tells us, we know more which joints are involved, and then the chiropractic exam also helps tell us, in terms of joint play and joint mobility, that can benefit from a chiropractic, more specific chiropractic adjustment. Which joints are involved there as well. So again, all these things are really important in understanding. From looking at it from a view, from a sky view, and then we also look and we whittle that down to a very precise view of every single joint, ligament, and tendon to see what they are doing and how they are involved. Right now, in this case, with this patient, the SFMA top tier screamed at global movement. Major findings were we had a limitation in the feet together deep squat, multi-segmental flexion, which is like a toe touch test, and the multi-segmental rotation, which again, this is a standing feet together rotating towards the side test. So we're not testing one thing in that, but there's kind of ways of checking things off the list. If we can do multi-segmental rotation, then we don't really need to look at rotation on many of the joints throughout, because one way or another, they're finding a way to get to that position, right? But they failed, so we need to make sure we understand all the joints involved in that motion and see which ones are the ones causing that limitation, right? Which is where that precise mobility testing comes from. But before we do that, we do the patient-specific broad movement testing. Again, he's a CrossFitter in snatching, so we did some gait analysis to see what's going on at the feet. Found some interesting things there. Both showed what looked like what you might call a flat foot presentation. In reality, that's more of an orientation of that foot into an everted state, which is where you can think the bottom of the foot starts to almost like rotate towards the side, towards the outside, which looks like the foot is pronating, but in reality, again, it's more of an everted state, which oftentimes happens or comes from a loss of range of motion up the chain, and which is the case here. He's perfectly capable of supinating, which is the opposite of a flat foot, bringing that arch back up, and he's perfectly capable of pronating from a supinated position. So he has that motion and mobility in there. He's just hanging out in a pronated state functionally, which means it's due to another reason up the body that we can help, which means that we can pull him back out of that everted state. All right, so that's what the gait analysis showed a little bit. And then again, we did him do some goblet squats, and just to see what happens when he goes into a deep squat, and if we weight it a little bit. Later on, wasn't day one, we also did some overhead squatting, of course, and just to see what happens at that foot and ankle. We had some videos that he had brought in, that he had been noticing that heel comes up, which is really what started this whole thing. So we had some videos of it as well that we could compare to and see. The precise mobility testing, here we found some hip internal rotation that was worse on the right side, his problem side, versus the left. He had 10 degrees versus 15 degrees. 10 on his right, 15 on his left. Also, ankle dorsiflexion was quite limited on both sides. And then his hip flexion, again, when we're being very picky with this hip flexion and all these precise mobility testings, those were limited to about 90 degrees on the right and then 100 degrees on the left. So we could crank his hip into 120 degrees of hip flexion. But before we started to see compensations and a back arching and the pelvis having to lift up and the other leg lifting up, was at about 90 degrees on that right side and 100 degrees on that left side, which is very important to see, because we really want to get that number up higher towards 120 without compensation. Ober's test, which is a test where we lay on the side, we can really take a lot to understand what's happening at the pelvis, the orientation of that pelvis with this test. Again, we had issues on both sides, indicating a pelvic anterior tilt orientation, which makes a lot of sense with the other findings we had. And then we had tibial internal rotation missing on both sides. It was quite lacking there. Right, so we know that, again, we did a lot more testing with the upper extremity and thorax, but just going to leave that out for now, focusing on this lower extremity and all the tests that we do for that. And then, again, just mentioning some of the pertinent ones that we found that brought back some data. Then when we did the chiropractic exam, we're really looking at the spine and extremity joint play. We found that the pelvis certainly was moved into extension on both sides. It was tilted into, it was an anterior tilt, which created some low back extension. That's kind of low back rounded state. The TL junction, where that mid back meets the low back, was certainly stiff. And then the whole thoracic spine, for the most part, had some restrictions into extension, which is really important for overhead mobility. Right, so that's important for, we had a lower mobility issue that we had noticed, but we always looked at that upper body and thorax as well, because if his shoulders and his thorax are limited, it's going to put more pressure onto that hip, more pressure onto that ankle, and we're going to ask more of it to pick up the slack. Now again, we're focusing here on the lower extremity, but we always did look at that upper extremity, found some pertinent things that we also worked on. But again, if we get back to the lower extremity, those were some of the more pertinent findings, and I can show you a quick video here of the tests that we did, some of the top tier tests. So just the gait analysis, and then or just a video of the gait. You can see a little bit of that flat foot, as well as the SFMA top tier stuff. So just the toe touch test and the multi-segmental rotation. Again, we did a lot more than this, but here's just a quick video, and I can talk over a little bit just to show some of the intricacies of these tests. We don't have any footage of the precise mobility test, and that was all taken by hand and measurements for the records to compare to later. Okay, first with the toe touch test or multi-segmental flexion, the feet are together. We have him bent over to touch toes, and it looks like he does a pretty good job. He's able to get his toes there. He has a nice backward weight shift, but we also see that there is some flat parts here at that low back, a little hinge point there, another section of flat, hinge point there, and then another section of flat. So this is telling us a lot about the spine, and we had mentioned earlier in the chiropractic exam there was areas of mobility loss in that spine, and this is kind of hoping to make some connections there as well to back up that finding. Like, yes, there's definitely some either motor control or mobility issues here, and then with that chiropractic exam saying, yeah, they were mostly, or at least mobility is involved here, some restrictions that chiropractic adjustment can help with. If we keep moving forward, this multi-segmental rotation, he says it's about right there, right? And we're looking at the pelvis first. It's just reaching about 45 degrees to say it's just a little bit short, saying, yeah, we need to look at rotation of these joints at the pelvis and below. And then we look at the thorax, and again, he doesn't quite make it there either. We want to see about 100 degrees, so we should see the shoulder pop out over here. And yeah, so we can see there's just some lack of rotation mobility here, and the pelvis up as well. So we're gonna look at both. Again, here we're just focusing mostly on lower extremity for the sake of this article and podcast. And he mentioned there he's got some cramping, so he had to work hard even to get in that position, and that's telling and important as well. Same thing here. Pelvis is getting maybe close to 45 degrees, but not quite enough. And then that upper extremity not making the cut. So we definitely need to work on some of those spinal mobility issues we found in the chiropractic exam, and with the precise mobility testing, the table testing that we did as well. And then last we can just look at gait a little bit. On the way back here, we can see how that foot likes to come down and then just drop right through into that arch, into more of an everted position. Okay, so the next major step here is deciphering all this information. Now, I've kind of been walking us through that process a little bit as I've been mentioning some things. But again, we're looking at that global movements that last video really showed. Some more precise testing. We had some videos of a snatch that he had showed me, some goblet squat stuff, some gait analysis stuff. All this tells a little bit more precisely on the activities that he likes to do. It's good to take a good look at that. And then that table testing stuff, very important. That's what tells us where the asymmetries. What can we start doing? Where's there a loss of shift? What side does he tend to stay into or shift into? How can we connect that to the loss of rotation at certain joints like the hips? So all in all, what we found here is that there's definitely some rotation, lower extremity rotation restrictions. There's some spinal mobility issues that we really need to work on. And there is a everted or kind of oriented foot that is trying to compensate for loss of internal rotation. So overall, his right hip is lacking internal rotation, and he struggles to actually shift into that right hip, which tends to be less common. But in this case, that is what his issue is. He shifts out of his right side more so into the left side. So what we need to do first is fix that pelvic orientation, that Ober's test and some other tests indicating that he's anteriorly tilted. So we're going to pull that pelvis back into neutral, because without that, range of motion throughout the whole body really will be limited. So we really need to make sure that we have that taken care of. After we have done some days, some drills, a couple treatments, we're really pulling that pelvis back in neutral, and we're teaching him how to breathe and expand through the rib cage and tuck those ribs down. From there, we can reassess, see if those mobility numbers have changed, and then really address the asymmetry. So it's kind of phase 2 is where are the asymmetries in his and his mobility. Now we already found some, but we want to see where are they now that we've pulled him back into a neutral pelvis and have been able to get that diaphragm to go straight down to the rib tuck, everything like that. And again, we still had an issue shifting to the right side with the right hip internal rotation mobility issue, and both feet were kind of showing an orientation into eversion. So we worked on pushing him out of his left side. So we worked on his left glute max a lot, did some drills there, and then we also are working on pulling him into his right side. So some groin adductor stuff on his right side, as well as some right hip mobility stuff. And that is kind of that phase 2 stuff. Phase 3 is when we really start to load it up, retest his patterns, kind of get him to use these changes, his new comfort in shifting to his right side, his new mobility on his right side, to sink down into snatches and now be able to replicate that stuff in a deep squat, replicate it under load, and then replicate it under speed and power like it is in a real heavy snatch, right? And so that's how we use all that data. Again, always addressing the spine, adjusting every treatment, making sure that we're doing some soft tissue stuff, and then just progressing him from phases 1, 2 up to 3 as the treatment sessions go along, right? So that is kind of the summary of a performance patient coming in with some issues, mobility issues, how we've tracked down everything, mainly focusing on that lower extremity. Again, I dove a little bit into that upper extremity. We always make sure we look at the full body because, again, we're talking about a snatch. In this case, we need to make sure that everything is dialed in. His foot heel was coming off the ground. He really struggled to be comfortable in that bottom of the squat. We need to know what his ankle mobility looks like, and we worked on that quite a bit. We need to know what his hip mobility looks like, and we worked on that quite a bit. But we also need to make sure that he is able to extend through his thoracic spine. He's able to stack his ribs over his pelvis in that deep overhead squat position, and that his shoulders have enough mobility to be comfortable there as well. Because if they aren't, then they are going to either to get him there, he's going to have to maybe orient or go dive into an anterior pelvic tilt, which will again ruin all his lower body mobility, which maybe was the cause of him having to raise his heel off the ground in the bottom or not be able to shift. Again, so we always make sure that we're addressing everything throughout the body, because one thing was certainly his right shoulder mobility issue could be affecting his right ankle mobility, which could have been the cause to his issues. Now, in this case, we really found it to be a pelvis and a hip mobility thing. But when we cleared up some ankle stuff and some upper extremity stuff as well, that's when we really got things moving to kind of put everything together, right? So I'll talk a little bit more in part 2 with to dive more into these treatment principles in this case. And again, if you ever had someone who had pain with any of this stuff, we would just focus more on symptom modification earlier on in phase 1, identifying the cause of the pain, and then otherwise the same thing is different because then we're just diving into finding the root cause of the pain, not what is painful, but finding what created the environment that the overload occurred at that one joint, which is basically everything we talked about today, is finding out where the connections are, the mobility restrictions, the stability issues, and the motor control issues that cause those injuries in the first place. So look forward to getting that out. We'll have more videos of the treatment, the actual exercise, mobility, and chiropractic adjustments and things like that, more in part 2. Otherwise, appreciate you guys listening. We will see you next week. Thanks. Bye.